Okay, so I think we're we're a few minutes past the hour, and so hi and good afternoon, everybody. Welcome to our weekly meeting for presentations and case hearing. Today we have the privilege of having Dr. Jay Banerjee speaking to us. Jay is a neonatal consultant at the Imperial College Healthcare NHS Trust, and he's an honorary senior clinical lecturer at the Institute of Reproductive and Developmental Biology at the Imperial College London. So he specializes in non-invasive research techniques assessing neonatal hemodynamics, machine learning of physiological parameters, and he studies long-term cardiovascular outcomes of prematurity at the Imperial, supported by Imperial NIHR Biomedical Research Center. Also, he's got significant interest in family integrated care research. He's a part of the perinatology research group at the IRDB. So, Jay, over to you, please. Thank you.
Thank you, Ahmed. This is slightly different than the presentations that we normally tend to do on the Friday presentations. So there is not going to be a lot of echo images or ultrasound scan images, which we'll show in this talk. But I'm going to open up an area, hopefully that all of you are aware of, which is looking into the vascular function rather than the cardiac function that we are more entrenched with. So the points today, what I'm going to talk about are firstly, looking into the developmental origins of cardiovascular disease risk. We'll go through some very briefly with some epidemiological studies and background, looking into how the hypotheses are generated around the vascular disease. I'll talk about some of the mechanisms that people, the researchers have been using over time. And then going into more kind of detailed mechanistic version, looking into arterial function and looking into both structural aspects as well as functional aspects of arterial function. What is the relationship between the different perinatal factors that we worry about and long-term cardiovascular disease risk? And then finally, I will give you some very early results from one of the studies that we have been undertaking at Imperial over the last 2 years or so. It's called BAMBI study. And that would be the kind of the model of talk today. So I would like to start with a picture of this man and this lady. So the man on the left-hand side of your screen is an Englishman. He graduated from the Guy's and St. Thomas's Hospital, had a significant interest in natural history. So he ended up going to Africa and did a lot of studies looking into the natural history of various disease processes. And finally ended up in Southampton and became a professor of epidemiology at Southampton. So whilst working there, he looked into the records of children who were born in the 1930s and in the area of Hertfordshire, and wrote this amazing talk, which is an amazing paper in Lancet, which have been then, became famous as the Barker's hypothesis. So this was David Barker, and he wrote this amazing kind of landmark article in Lancet in 1989 and called it very simply, Weight in Infancy and Death from Ischemic Heart Disease. And this is the first time ever people started looking into the relationship between the weight of the babies at birth and the risk factor of cardiovascular diseases. However, weight and in infancy could be small because of various reasons, as we know. It could be babies are born preterm. It could be babies are born small for gestational age, but it could also be babies who has got fetal growth restriction or FGR, previously known as IUGR. And because of these reasons, if you consider in the current day and time, perhaps Barker's hypothesis needs more clarification because it only talks about small babies. It doesn't talk about any of these phenotypical groups. Now, the picture on the right-hand side of your screen is a very famous actor from Hollywood. In 1940s, 1944-45, an area of Netherlands was occupied by the Germans during the Second World War, towards the end of the Second World War. And that area was completely cut off from all the supplies that could reach there. And this resulted in something which is well known in the history as the Dutch famine. And this Dutch famine, when the children, and because there was absolutely no supply of food and even bread or milk, everything was at scarcity. And this resulted in babies being born or mothers who were pregnant having very little or no nutrition during this period. And this resulted in them delivering babies who were smaller, who had growth restriction, and who had other consequences. And after obviously the liberation in 1945, all these resources then came back to normal. But there was an epidemiological study that followed these babies throughout their life course, and even after these the girls who were born when they gave birth, they also shown that the girls when they gave birth, their offsprings also were small. They also had problems with fetal growth restriction. This is called the Dutch famine birth cohort study. And Audrey Hepburn was one of these girls who was born during this period, during the Dutch famine. So what is the relationship between prematurity, fetal growth restriction, and cardiovascular disease? So again, a couple of epidemiological studies. The cardiovascular risk in the Young Finns study looked after more than 3,500 children and adolescents between the age of 3 years and 18 years. And they found smoking, increased blood pressure, arterial stiffness were all associated with increased risk of cardiovascular disease. They did a cross-sectional study at 31 years of age, and they found babies who were born small for gestational age. They defined this as less than 10 centile at birth. These babies had worse lipid profile with higher cholesterol levels and triglycerides, higher systolic blood pressure, and higher arterial stiffness. And another large epidemiological study from the UK followed up children who were born in Cambridge and Wales. And they looked after more than 3,000 children who were born during that period. And a long-term follow-up of those children at around 21 years of age showed increased systolic blood pressure and central pulse pressure in the small for gestational age babies. And they defined just small for gestational age those who were born at less than 9 centile at birth. You have all heard of the EXPRESS cohort study from Sweden. They did some mechanistic studies looking into the diameter of the arteries in the babies who were born with fetal growth restriction. And they found that babies with fetal growth restriction has much smaller arterial diameters compared to their appropriately born counterparts. This led to several small-scale mechanistic and observational studies looking into the arterial and structural and functional assessments of babies who are born premature, those who are born with fetal growth restriction, and their relationship with arterial stiffness. A systematic review and meta-analysis was published in 2019, and it showed that the babies who were born with who were born preterm, babies who were born preterm had stiffer arteries. They have got higher systolic and diastolic blood pressure, and they also have abnormal cholesterol levels. They also have higher insulin resistance as well. These babies were also noted to have higher fat mass compared to their AGA, compared to their non-preterm counterparts. Preterms also had a higher risk of developing higher diastolic blood pressure, which means that higher blood pressure in this group of babies. So what is there are different hypotheses there that how this can happen in babies who are in this environment growing with fetal growth restriction. And they look into at a population level, at an individual level, as well as at a molecular and genetic level. And what they think that these children have already pre-existing genetic susceptibility. And on the top of that, when there is environmental exposure, it leads to this idea of two-hit hypothesis, resulting in development of cardiovascular diseases. So the genetic susceptibility is predominantly because of conditions such as maternal preeclampsia, fetal growth restriction, and even prematurity. And all these things can lead to genetic susceptibility to develop cardiovascular disease later on in life. On the top of that, when these babies are born preterm, they also receive nutrition in a very non-physiological way. They also create what we call a catch-up growth, and this can all result in things like insulin resistance because they grow very fast. They have got very high insulin levels as well. So we think that the genetic susceptibility and environmental exposure can result in some epigenetic changes. And these are mainly threefold. They thought about things like DNA methylation, histone modification, and microRNA dysregulation. And finally, all these the double hit of genetic susceptibility and environmental exposure leads to abnormal protein synthesis and resulting in, for example, stopping of elastin synthesis in the arteries, resulting in stiffness of the arteries and therefore hypertension. Things like hyperlipidemia or dyslipidemia, problems with dysregulation of the insulin resulting in diabetes. And all these things can result in finally development of coronary artery disease and stroke. But there are two main pathways of development of cardiovascular disease. One is obviously cardiac remodeling, and the other is to do with the vascular changes that could happen during this period. Now, the primary changes of cardiac remodeling happens at the organ level as well as the cellular level. So at the organ level, there is a hypertrophy of the heart. First, there is dilatation of the heart, then is followed by hypertrophy of the heart. And these are secondary changes because of the hypertension. In addition, the cardiomyocyte, they get altered. The direction of the fibers in the cardiomyocytes or the cardiac fibrils within the ventricles gets altered during this process of development of the fetal growth restriction and other things. And in addition, the cardiomyocytes itself, it becomes polynuclear or multinuclear compared to what it normally is a uninuclear. In addition, there is arterial functional alterations because of raised systemic vascular resistance. and this causes vascular changes. In addition, there is atherosclerosis because there is dyslipidemia and deposition of the lipids around the arteries. And I told you already, so because of this abnormal genetic dysregulation, the elastin production stops. It can stop as early as in utero. So the elastin doesn't produce anything any further, resulting in more stiffened arteries. And on the top of that, there are endothelial changes that can happen during this period. So in summary, you can imagine that if someone has a placental insufficiency, there's obviously undernutrition, there is a double hit of fetal hypoxia, and then there is volume or pressure overload due to the placental resistance. And because of that, there are 3 different phenotypes of cardiac remodeling that can happen. In the beginning, there would be left ventricular remodeling. So left ventricular myofibrils around the left ventricle becomes abnormal, and it becomes what we call an elongated phenotype. So the left ventricle becomes bigger. This followed by the fact the right ventricle starts to get bigger, and it develops what we call the globular type of heart. So the left and right ventricle both becomes bigger, but the muscles still hasn't grown bigger. And this finally results into the 3rd stage, which is called the hypertrophic phenotype, where both the left and right ventricular hypertrophy starts to happen. And we all think this is to do with all the 2-hit hypothesis I was talking to you about earlier, and the epigenetic changes that can happen at the subcellular level. So what can we? So what actually happens over the period? When is these changes happening? We believe that the majority of these changes and the impact on the fetal, the long-term impact on the fetal growth restriction happens in in utero stage when it's in the fetal stage. And in the fetal stage, we can see remodeled hearts. We can see increased intima medial thickness of the aorta, and we can see these abnormal atherogenic lipid profiles. There's also reduced nephrons in the kidneys in the babies with growth restriction. As this fetus is born and become child and grows through the process of maturity, the remodeling and the changing just accentuates rather than it becomes anything new or any newer mechanisms starts. And therefore, the opportunities for correction or treatment or management of these is the maximum when this child is a fetus rather than when they're older. And even that, you will see that throughout, if you look at the management of cardiovascular disease in the UK or anywhere in the world, majority of the cardiovascular interventions generally happen at the old age or after adulthood. So are we actually missing the trick? Are we actually treating this group of individuals much later when probably there is very little we can do to modify their disease process? Just coming back a little bit about arterial stiffness and its relationship with cardiovascular disease. The Framingham Heart Study showed that cardiovascular disease are not only associated with those with high blood pressure, but it can also happen those with high normal blood pressure. So this led people to understand how does normal or high normal blood pressure can also be a strong risk factor for cardiovascular disease. The Enigma study from the UK showed that males with hypertension had a predominantly cardiac phenotype, whereas females with hypertension have a higher degree of systemic or peripheral vascular resistance and arterial stiffness measures. So what they tried to say that hypertension in males are more cardiac, whereas hypertension in females were more vascular. And therefore, there is a difference there, and therefore the treatment has to be different in either group of individuals. You all have heard about the Epicure study and of the babies who were born preterm in England, and you've heard about the neurodevelopmental outcome, etc., etc. But very little has been advertised, if you like, in terms of the cardiovascular outcome of these children. So at 11 years of age, the EPICUO study did a follow-up of these babies who were born extremely preterm, and they compared them with sex-matched controls. And they showed there are significant higher arterial function measures in those who were born extremely preterm compared to their control group. There was also about similar time another study was published in the UK, which looked into the relationship between maternal anemia, maternal iron levels, and arterial function in babies. They found there was a relationship between maternal anemia and arterial function, but actually there was no difference when they looked into the ferritin level and the iron level in pregnancy and this relationship with arterial function. So Roshni, one of my my previous research fellows, did this fantastic diagram trying to put all the things together in terms of the different arterial stiffness measurements. And here you can see, and I'll talk in a bit more detail, these different measurements, because these measures are quite important for us to understand what we are interpreting. So first and foremost is arterial structural measures. Intima media thickness is one of the very widely used parameters of arterial structure measurements, of function measurements. And on the right-hand side here, you can see an arterial lumen, and this is an abdominal aorta. And here you can see the thickness, how it's measured. And basically starts from the between the junction of the lumen and the tunica intima, and the junction between the tunica media and the tunica externa. So normally you will those who measures aortic posterior wall thickness, you will see that there are generally, like when you do the ultrasound, you will see two layers. So the two layers, the first layer is the tunica intima, and the second layer is actually the tunica externa. The tunica media is generally quite hypoechoic. And generally, this is how we can actually differentiate between the tunica media and tunica externa. Unfortunately, this is not very easy to measure using a normal ultrasound scan machine, but you would be able to optimize if you have an echo pack or a processing software. You'd be able to then modify that software to try and measure it, because the measurement are in micrometer, so it's much smaller than a millimeter in size, especially in a term or preterm babies. The carotid intima media thickness is another measure of arterial stiffness that has been used in adult medicine, and it has got strongly associated with development of stroke or cerebrovascular accidents. And generally, you identify the common carotid artery. We generally tend to identify the right common carotid artery, and just before the bifurcation of the internal and external carotid, that's where you start measuring, and you can again measure the thickness of the posterior wall of the common carotid artery using the same technique. And I also wanted to tell you that there are two levels, if you like, in terms of how the arterial stiffness changes. So one is at the level of the wall, where there is perhaps abnormality of the elastin or absence of elastin, and it results in increased stiffness. And secondarily, there is a development of atheroma or atherosclerosis. Atheroma production over time starts with a fatty strip, then there is an intermediate lesion followed by atheroma, and then it develops into fibroatheroma and complicated lesions. Obviously, for our point of view, we don't see anytime actually these lower 2 or 3 levels of atherosclerosis. But it has been shown that atherosclerosis can start as early as very early infancy. Another measure of arterial function is to look into what we call the stiffness index. And I think we commonly use that in certain cases where we look into difference in the diameter of the arteries in the aorta, for example. So in this study, this is the Express cohort where they from Sweden. They looked into the abdominal aorta and the carotid arteries, common carotid arteries, at around 6.5 years of age. And they compared those who are extremely preterm versus a control group. And they found the stiffness index was definitely much smaller in babies of the common carotid artery in babies who are born extremely preterm. They didn't find this difference in the abdominal aorta, though. They mainly, the difference in the stiffness index was in the common carotid arteries. And next, I'll come to some of the bit more complicated kind of arterial function measurements. This is actually very commonplace in adult medicine. And this is one of the most important functional measures that's used to understand your cardiovascular disease risk as an adult. Let me just walk through it with you slowly. So this baby here, you can see there's a BP cuff, which is put in the arm, and there is a BP cuff, which is put in the leg. This machine, which we use called Vicorder, there are other machines available. This machine then connects through these two BP cuffs, and it inflates the two BP cuff at the same time. And after it reaches a certain level, it starts deflating. And then the machine picks up the pulse on the arteries, so the brachial artery in this case, and the femoral artery. So what is a pulse wave velocity? So when the heart contracts, apart from the blood which goes from the left ventricle in through the aorta to the rest of the body, there is also a pulse or a ripple that goes along the arterial wall, the aortic wall. And this ripple is what you call the pulse wave. So suppose if the pulse starts from the base of the aorta, and you are measuring the pulse at the radial artery, so you would be this pulse will obviously reach the radial artery after a certain point, after a certain time, which may be in milliseconds, but this is what we call the pulse transit time. So the pulse that comes from one place to another place, the transit time is called pulse transit time. And here it's denoted as delta t, difference of time. And so if you know the distance between, for example, the base of aorta and the radial artery, and if you know the transit time, you'd be able to then measure what you call the pulse wave velocity over meters per second. So here, what you can see, there are two waves there. So the top wave, imagine it's in the brachial artery, and the bottom wave, imagine it's in the femoral artery. So you can see the peak of the two waves and the trough of the two waves are slightly different to each other. And this is because of the time the pulse is taking to go from the brachial artery or from the end of brachial end to the femoral end. And this is called, this is denoted as the pulse transit time. And using an algorithm, then you can actually measure, and if you can tell the distance between the arm and the leg, you would be able to then tell what is the pulse wave velocity is. So, so if you imagine that if the arteries are stiffer, then the pulse wave velocity should be faster because the pulse is not able to ripple through the arterial wall. It goes fast. And therefore, the more stiffer your arteries are, your pulse wave velocities will be higher. So augmentation index is another kind of measurement, very similar to the pulse wave velocity, which measures certain further parameters to get an idea of wave reflection or the pulse waves. So we did a systematic review, which was published last year, looking into the impact of the perinatal factors or the different perinatal factors on the biomarkers of this cardiovascular disease, mainly looking into the pre-adolescent children. And the reason we chose pre-adolescent children, because we know there are a lot of other factors that interfere or intervene after adolescence, including hormones, food, smoking, etc., etc. So we divided them into three different groups. We had about 52 studies. We divided them into maternal factors, preterm or prematurity, and then looking into the birth weight with fetal growth restriction or SGA. We had mixed results with maternal blood pressure. So one of the studies had an inverse relationship, which means that if the mother had a lower BP, then the babies had higher aortic pulse width velocity. And then some other studies that looked into relationship between gestational hypertension, preeclampsia, they also didn't find any association between carotid or radial pulse width velocity and flow-mediated dilatation. And they also showed no association between brachiofemoral pulse width velocity and maternal blood pressure, which was measured during pregnancy. And I told you earlier, there are some relationship between anemia and arterial stiffness, but when they looked into the iron status of the mothers, there was no relationship there. But when they looked into other factors such as diabetes, obesity, and use of metformin in mothers, they found there was strong positive association between those who had diabetes or gestational diabetes along with metformin and those who had higher HbA1c or those who were obese with higher arterial stiffness. So there was positive relationship there between all these metabolic diseases, metabolic factors, and arterial stiffness. They also looked into the stress level of the mothers, looking into their maternal salivary cortisol and their psychosocial level of stress. And they also found there was some relationship there. When they looked into nutrition of these mothers in pregnancy, they found that oily fish consumption resulted in reduced arterial stiffness in babies. And on the other hand, exposure to alcohol had a higher risk of increased arterial stiffness in the babies. When we looked into the prematurity, and the first two papers are from the cohort of Epicure's cohort, they showed that aortic augmentation index was 5% higher in the preterm group. And those who had abnormal lung function, those preterms who had abnormal lung functions, they had even higher augmentation index. Arvind Segal's group from Monash in Australia, they looked into the relationship between bronchopulmonary dysplasia, hypertension, and arterial stiffness in prematurity. We have actually invited him to speak about his papers, amazing papers he has written on arterial stiffness and his relationship with prematurity, bronchopulmonary dysplasia, etc. So we will hopefully do that presentation sometimes in end of February. Another group looked into a relationship between prematurity and the nutrition in the prematurity, and they found that those who had higher lipid intake or lipid therapy or intralipid during their treatment in the neonatal unit, they had higher incidence of developing higher arterial stiffness. 6 studies looked into aortic intima media thickness and unanimously found the aortic intima media thickness to be higher in the SGA and FGR groups versus the appropriately grown babies. And when they looked into the carotid intima media thickness, there are 5 studies which showed some mixed results, but actually showed that use of omega-3 oils in childhood can reverse this inverse relationship of birth weight with carotid intima media thickness. Aortic stiffness index, as I told you before, there were 10 studies which showed that higher stiffness index was found in SGA and FGR groups, but there was no difference between the groups in 3 other studies. And similarly, pulse wave velocity showed higher pulse wave velocity in SGA, FGR, and low birth weight groups. This is looking into the EXPRESS cohort of babies from Sweden. And there was inverse association between carotidofemoral pulse wave velocity with birth weight at 9 years. But so these last two parameters, if you look, carotidofemoral pulse wave velocity and the brachiofemoral pulse wave velocity, they both had they both had increased risk of higher pulse wave velocity at a later age, like at 8 or 9 year old. But when you look at them earlier, at 6 year old or even earlier, they had no difference in their pulse wave velocity. And this can make you think that actually this arterial stiffness progresses over time. So perhaps if you look at it earlier, you might be, if you can get or identify the babies whose arterial stiffness will get worse, it might give you a window of opportunity to treat. But there were limitations when you looked into these systematic review. The sample sizes were small in some studies. There was a wide range of population studies. One of the biggest problem in babies who are denoted as small or SGA, there is very little in terms of definition in terms of who were SGAs, who were babies who they classified as fetal growth restriction, and who they classified as low birth weight. And also some of the parameters, when you look into more details, the mechanistic studies, they only took, for example, 1 maternal blood pressure during the whole period of pregnancy, or 1 HbA1c level during the whole period of pregnancy, which actually doesn't adequately reflect the environment of the fetus throughout the pregnancy. But obviously, association is not equals to causation, and there are several unmeasured confounders there. So there was a mixed bag of findings, but aortic intima media thickness was universally the most consistently higher in the low birth weight SGA or FGR groups compared to the appropriately grown babies. So we think more or larger studies using standardized validated techniques and clearly defined groups are needed. And in future, maybe a randomized control trial or interventional studies could be used to explore the efficacy of these different risk factors and how we can modify, how we can intervene and modify these risk factors of cardiovascular diseases. So we are currently running a study at Imperial called Bioimpedance and Arterial Function Monitoring at Birth and in Infants. Because the study is still running, we don't have all the data with me, but I'm just going to show you some of the preliminary findings and preliminary data, and the methodology, of course. The principal objective was to assess the feasibility of non-invasively measuring arterial and cardiac structure and function in appropriately grown, small for gestational age and growth-restricted babies in preterm and term gestational ages. Our secondary objective was to assess if pulse wave analysis could be used as a valid method to non-invasively assess not only the arterial stiffness side of things, but also stroke volume and cardiac output. And we also wanted to describe the neonatal arterial and cardiac function in appropriately grown, small for gestational ages and growth-restricted babies in the early newborn period, as well as 6 months of postnatal age. And again, I'm just going to very briefly show you some of the results. We used the Delphi classification that was published in 2016 by a large consensus definition group from the obstetricians, fetal medicine, parents, and perinatologists. And they defined those with fetal growth restriction very clearly using some biometric parameters as well as some Doppler parameters. And we're using this to then define who are fetal growth restricted babies, especially those who are born at more than 32 weeks, because it's quite, the definition used to be quite fuzzy before this Delphi definition came out. We have two different study groups, and within the study group, we have babies who are born with small for gestational age and babies who are born with fetal growth restriction. And then we have a control group of appropriately grown babies. We divide them into less than 32 weeks and more than 32 weeks. And then also we do further sub-analysis if the mothers had preeclampsia or not. So parents were approached, consent obtained in the initial period, and then we do the measurement around 33 to 36 weeks of corrected gestational age for the preterm babies. And then in the term babies, it should be done before the babies go home. And then for the preterm babies and the term babies, we ask them to come back at around 3 to 6 months of age and in corrected age for preterm babies. And then we do their measurements again. So the measurements performed are arterial structure measurements using the technique of CIMT and AIMT, as I told you before. We also do an echo to measure the stroke volume and cardiac output. We also use the non-invasive cardiac output techniques. And in addition, we use bicorder to measure the arterial stiffness in these babies. So it's exactly the same measures that are done at 33 to 36 weeks of corrected gestational age, and then 3 to 6 months of corrected gestational age. So these are the three main kind of methodology, if you like. And these are some of our babies who are sorry, it's not chronological age, it's a corrected age. So these are 24-weeker baby who on the left-hand side of your screen, you can see their abdominal aorta at 33 weeks. And on the right-hand side of your screen, you can see their abdominal aorta at 6 months of its corrected age. I'm sorry, it's not chronological age. And you can see that there are already showing some changes in terms of the how defined the posterior wall of the artery abdominal aorta is. And I haven't, we haven't got enough data at the moment to show you the difference between the two, but I can only tell you that it looks quite different between the two. And then when we look at the carotid artery intima media thickness, so this is how we measure, and then again we have to use this, put this as a post-processing software in the echo pack, and then we can measure the thickness of the wall. And you can see already, if you look at here, the posterior wall, you can see there are two lines there. And again, as I was telling you before, you start from the above up to the beginning of the next line, which tells you the thickness, the intima media thickness. And then I'm just going to show you a very quick video just to show how we measure the pulse wave velocity. So here, obviously, we're not using a real baby. You can see instead of babies, we have just put two cuffs on the two fingers of the two hands. And you will see this line that comes out, and we'll attach it to this two BP cuff. The software is already loaded into the computer, and you can see the machine in the just below the computer over there. The red line is indicated for leg, because apparently red line is for the arm, because R for arm, and then the blue is for the leg. So we then so this is how the software will look. And then we press one of the, so we first need to make sure that the data is coming through. And when we are happy with the data coming through, we press the space bar, and it then kind of inflates the cuff to a certain level, and then it deflates the cuff. And then you will see the pulse wave will start to come. Okay. So as soon as the software detects few stable pulse wave, it starts showing the pulse wave velocity and the augmentation index on the right-hand side. And then we can just, then we save these values, and then finally we can use it to analyze it and post-process it. So we have so far, I think a bit more than this. So we have so far recruited 31 appropriately grown babies, 7 SGA babies, and 12 FGR babies. And this is all because of this anomaly called pandemic, which happened when we started this project. And you can see the follow-up is not been great. We have managed to follow up a very small number of babies, more probably the fetal growth restricted babies, and some it's AGA babies, but very few SGA babies. And what we can see over here is some of the pulse wave velocity measures. On the left-hand side, first you can see the appropriately grown babies, then the SGA babies, and the third column is the FGR babies. And here you can see that actually compared to the what we think, the FGR babies have got lower pulse wave velocity compared to the appropriately grown babies. And this is persistent at the second measurement as well. So the box on the right-hand side of your screen is the second measurement done at 3 to 6 months of corrected age. And here you can see the pulse wave velocity, even from the AGA point of view or FGR point of view, have increased from the first measurement. But again, consistently, the AGA babies have higher pulse wave velocity compared to the FGR babies. And this is again just to show the difference between the first and second recording for the AGA and for the FGR babies. We also found on the first recording, as I told you, we did some further analysis, and we saw that the FGR babies have definitely got much lower pulse wave measurement, pulse wave velocity measurement compared to the AGA and SGA babies. So we think there is still lots to do. We are still collecting data, and hopefully at some point I'll be able to present the whole data set very soon. We have got an extension because of the difficulty in collecting data in during the pandemic period. This is, I think, of course, a very potential rich area for future research. Very little work has been done into this area of research. One of the biggest challenges are obviously movement artifacts, the follow-up of patients, as we have seen for the period we studied. We think low birth weight is strongly related with increased cardiovascular disease and cardiovascular mortality. So this is from all the epidemiological studies and all the systematic reviews and meta-analyses that I've shown to you before. We think arterial stiffness is a strong risk factor for hypertension, coronary artery disease, cardiovascular disease, stroke, and mortality. We think that SGA and FGR babies, when they're older, they have worse arterial function. They are at a higher risk of developing cardiovascular disease and cardiovascular mortality. But whether this arterial stiffness and arterial function worsens very early or actually in the late childhood, this is something that needs long-term follow-up studies. And if you can actually detect the group of babies that might potentially develop worse arterial function and higher arterial stiffness, it might be a very important area of research, of interventional research, where nutritional modification or or medications can potentially change the outcome or long-term outcome in these babies. And I wanted to finish with my gratitude to the 2 centers that I work in Queen Charlotte's in Chelsea and St Mary's Hospital in London. And I want to thank all the members who have been really helpful to me during this project. And thanks especially to Roshni Mansfield. She was my research fellow during this period. So I'll stop it here, and I'm happy to answer any questions.
So Jay, I'll wait for the audience to raise hands. I can't see any. So in the meanwhile, can I ask a question?
Yeah.
I have two questions, but you don't have to answer the second question. The first one is that so how much of this at the moment is part of your current practice, the existing practice? How far are you actually doing the identification, risk assessment, monitoring, and then earmarking babies for follow up, and to be identified for a certain intervention later on? Is it, have you to any extent started this, or this is all a bit of a future thing you talked about?
I think this is we are far away from it. We are very far away from it. I think this is at a very early stage of research at the moment. Um, I think one of the things that we can very easily do, it's not about doing the screening, but also you have the screening tool has to be quite simple and
Mm.
easily doable. So one of the things that we have now started to do is to look into the blood pressure of these children when they come into the in the outpatient clinics. And you will hear from Arvind, hopefully when he talks in February, and the group from America. They have also shown that these, especially babies who had got bronchopulmonary dysplasia, preterm babies with bronchopulmonary dysplasia, those babies are at a very high risk of developing hypertension and therefore left ventricular hypertrophy and heart failure subsequently. So and actually this could be modifiable because there are medications there are nutritional interventions there that can help modify this hypertensive process. Some of this is not modifiable. For example, small for gestational or IUGR babies will have less nephrons in their kidneys, and therefore the hypertension risk arising from that part of their condition is non-modifiable. But there are certain things that can be modifiable. So I think we are scratching the tip of the iceberg at the moment. I think this is potentially a very huge risk area of research that we haven't looked into, and we should.
Great. So I think we have little time and a couple of hands up. So um, uh, I will not ask the second question regarding Audrey Hepburn. So so Mahmood, you wish to ask a question?
Yeah, thanks, Jay. That was fantastic talk, and you just opened our eyes to lots of things that actually we're not aware of. And once the baby leaves the NICU, there are plenty of things happening afterwards that we should pay attention to. So my question to you, you already touched base about the bronchopulmonary dysplasia. We know that the fetal growth restriction and SGA babies are more prone to develop pulmonary hypertension during their NICU stay, particularly if they are multiple pregnancies. How many of your babies have had this pulmonary hypertension? And do you believe there is like cardiopulmonary vascular disease combining both systems?
Yeah. I can't tell you the numbers top of my head, but there are quite a few. Whether there are a few babies who actually had home oxygen when we did these measurements. So when we get more data and trying to kind of pull through all the data, I'll be able to answer that question. But the vessel is a vessel. So there are we always think of the loading issues, which is to loading of the right ventricle, loading of the left ventricle, and therefore probably the vascular structure might be different in those two cases. But we don't think of the inherent problem, which is the elastin synthesis and other problems that happens in the wall of the arteries. And I think this is where I just wanted to open this area of understanding that actually we are very naive if we think that are the only pathogenetic mechanisms. There are loads of other mechanisms that is modifiable or non-modifiable that might have already happened as a fetus. And it's like, so I generally give the simile of a rocket firing. So when the rocket is firing at the base, if it is 0.5 degree apart, you probably don't think of much. But when it is few light years away, you will know how different it is, how far it is away from the target. And I think that's how you can imagine how the simile with fetal growth restriction is.
Thanks, Jay.
Yeah, I think Liam, your hand is up, please.
Hi, Jay. I'm Liam, so I'm from Bristol. I just want to say thanks for the talk. It was great. And also your recent study in archives was brilliant as well with the non-invasive markers with LVR. I thought it was great. I just wanted to quickly ask, a bit of piece really with the pulse velocity waveform, because we did some work like a few years ago looking at something similar, but with pulse oximetry.
Yeah.
And I just wondered, applying your kind of technique or these kind of techniques acutely, whether actually with arterial stiffness measurements, whether actually that can be applied to sort of measurements of SVR or something like that, because we have measurements of cardiac outputs, but actually measurements of SVR are difficult to come by. And I just wondered if there was anything looking in acutely into the technique that you looked at with pulse, pulse waveform velocity, or if there are other things that you've come across in your reading where we could look at measurements of SVR in the acute period, not necessarily obviously the long-term arterial stiffness, which your researchers or what you're looking into at the moment.
Yeah, I don't know whether there is any work been done in that area. So you will know in adults, they use pulse wave velocity in two cases, so two different ways. One is obviously looking at the cardiovascular risk. The other one is to look into things like peripheral arterial diseases. And I'm not sure whether they look into systemic vascular resistance directly, but what we try to do using this technique is that using the pulse wave analysis, you can actually it gives you a value for the stroke volume as well, and because you can measure blood pressure, so you might get a derived value, but I'm not sure whether you can get a direct value of systemic vascular resistance using this. Something that we can look into, I'm sure. It's nothing. Yeah, it's not out of bounds, I think.
Thanks very much.
Okay, we're done.
Yeah. Mark, are you wanting to make any comments or question?
No, sorry, did I raise my hand? No. Sorry, Ahmed. Thank you.
Great. So I guess
Can I ask just a quick question, Ahmed? Sorry, before we finish. Jay, I know you've been doing some work about chronic pulmonary hypertension in BPD babies. Do you have like specific follow-up clinic for those CLD babies? And do you see any worsening in those cohort of babies you are looking at in your recent study, i.e. More requirement for home oxygen, more hypertension, all those kind of things?
So this is something that we are kind of planning. I don't think we are doing it as yet. So we are trying to have kind of a pathway, if you like, on how to assess these babies, both cardiac as well as the vascular function, right from the beginning. So so after the BPD toolkit came out from the BAPM, we're actually planning to do something which would be very similar in line with the BPD toolkit, but maybe slightly more than that. So we're going to try and do cardiac and arterial function as early as 10 days, 7 to 10 days, and then later at 32 to 34 weeks, and then in the follow-up in the clinic. And hopefully we will be able to understand the difference between, as you said, the pulmonary hypertension, the systemic hypertension, because there are two different pathogenesis and two different phenotypes. And we have to try and tease between the two because the treatment is obviously quite different between the two.
Yeah.
Okay, I mean, lots of rich area there to work on.
Yeah. That's great. Thank you very much. Fantastic.
Yeah, Jay, thank you so much for a great talk, really. And We'll see you next week, hopefully.
Thank you. Thank you.
Okay, bye-bye. Cheers.
Thank you.